Hello and welcome to one and all. I welcome you all to this amazing another discussion on the breast cancer awareness series. I am Dr. Asavri Sawant from IHW Council, and this breast cancer awareness series initiative is by IHW Council and Rapid and is being supported by Roche. As we are in the breast cancer awareness month currently, we are doing this brilliant initiative to raise awareness on the topic of breast cancer. This episode will specifically talk about the topic of breast cancer stages and types so that our audience is able to understand what the different stages and types mean in breast cancer, as these play a very crucial role in accurate diagnosis. So awareness is very much necessary. For the same, we have a very eminent panelist here with us. We have Dr. Vinu Sarathy, who is a consultant of medical oncology with Baptist Hospital, Bangalore. Sir, we welcome you to the show. Thank you so much for joining us.
Thank you so much, ma'am. At the outset, thank you for the kind introduction. Thank you to Roche and IHW for having me here. It's indeed an honor, and I'll try to do my best at explaining regarding breast cancer and spreading awareness. Thank you.
Thank you so much, sir. So let us start our discussion. So as breast cancer is a complex disease and understanding its stage and types is pivotal for effective management. To guide us through this discussion, we are very fortunate to have you. So the first question that we would like to know is, let's start by discussing what are the different stages of breast cancer. And could you also walk us through how it is important to understand these stages for accurate and essential diagnosis?
Yes, ma'am. So with any cancer, of course, we do have staging. So staging is more, it helps us understand how big the cancer is, how early we have caught it, and hence we can also determine the treatment based on the stage. Okay, and the staging also helps us know like what are the percentage of cure. So that is the main thing with regard to staging. Okay. But I would also like to add the point: the stage does not mean everything. Okay. So it is definitely a very important point. So for staging for breast cancer, especially, we mainly use the first primary thing is called the size of the lump. Okay, because almost all breast cancers present with a painless lump. Okay, the first thing which is noticed by a woman or any patient is a painless lump, because breast tissue is a superficial tissue. It's not deep seated like stomach or intestines or pancreas, where it is detected late because it is growing deep within and you don't get to know. Breast cancer is detected early most of the time because it is a lump just under the skin, which most of the time the patient themselves feel and they come to us. Okay. So for the primary thing, what we say is a TNM staging. T stands for tumor, which we use for the lump or the size of the breast mass. The next is called N. N is node. Node means all the breast tumor or the breast tissue itself, they all drain into some localized, like a surveillance stations called lymph node, which helps protect, which has the immune cells protected from infection and also cancer. So those main nodes are present in the armpit, or what we call the axilla. So first the breast cancer starts from as a lump in the breast and then moves into the armpit. So that is called nodes. So we also see how many lymph nodes are there. So that can be found out by either clinically examining, where if it's big enough, we can feel it by ourselves. And also we use radiology techniques like mammogram and ultrasound and scans to find it. And finally, M staging is the tumor present only in the breast or under the armpit or gone to a faraway site, like maybe lungs, brain, liver, and that helps us to determine whether it is just a localized disease just within the breast and lymph nodes, or it is gone to a far off organ. So this is briefly what the three parameters we use for staging. So early breast cancer, we say, is where the tumor or the mass is localized only to the breast and maximum to the armpit. Okay, but if it is gone beyond that, it is gone above your collarbone, or it has gone beyond that to your neck or to your lungs or liver, then we call it advanced breast cancer. So for all sakes, we have it as a local or early breast cancer, and advanced or it is spread to distant sites apart from the breast. So this is what. Why it's important for us is in early breast cancer, the cure rates can be as high as 8 or 9 out of 10 women can get cured. But the same thing falls dramatically low in stage 3 if it's gone to the above the collarbone, or it is the lymph nodes are significantly involved, then it may come down even to 4 or 5. And of course, in stage 4, we know with spread to distant organ, the chances of cure becomes very low. So this is in brief what we call staging.
Thank you so much, sir, for so nicely explaining the different stages. So these are the staging when we talk about on breast cancer. So are
Yes.
the stages different from types of breast cancer, or are these two same? If they are
Yeah.
different, can you please talk about what are the different types when it comes to breast cancer?
Yeah. So previously we would say this was sufficient. Okay. It was like all breast cancers were handled the same way. And then recently, with more knowledge about breast cancer, the way the pathogenesis or the way it evolves, we have found out that there is an additional entity called, we also take the breast cancer cells and examine them under the microscope, and we use special stains to see if the breast cancer stains for something called hormone receptors, the estrogen receptor, the progesterone receptors, and there's also one more receptor called HER2 new, HER2 new we call it, and we also use something called a replicative index called Ki-67 that shows us how rapidly the tumor cells are growing. So recently they have found out that the hormone positive, which means estrogen receptor, progesterone receptor, if they stain strongly on the breast cancer cells, they are a more slow growing type and they do much more better. If they are the HER2 new type, they are a little more aggressive type. And if they do not stain for either of these stains, we call them triple negative, because all three receptors are not stained and they are the most aggressive ones. So what we say is, when they are hormone positive staining, we know that they resemble more closely to the original breast tissue and they are slower growing. But when they lose these, they become a rapidly aggressive variant. So this has also been included into staging these days. Okay, so you may have early tumor, but with all ER, estrogen receptor, progesterone receptor, HER2 receptor, all negative. But even then, it is a more aggressive variant. But sometimes you may have a stage 2, but hormone receptor positive, which may behave much more benign or much more slow course of growth. So these days for staging, we have the size of the primary breast mass, the lymph node, the staging by a scan to see if it's spread to distant organ, and this ERPR, which are special chemical stains we use to stain the receptors on the breast cancer cells and the HER2 new. We need all this to finally come to a conclusion which stage the cancer is.
Thank you so much, sir, for so nicely explaining these. How essential is it to distinguish between various types of breast cancer, or for staging of accurately of breast cancer? Why is it even necessary in the first place? Can you please explain to our audience?
Yes, ma'am. It is. This is necessary because first thing is it tells us how aggressive the cancer is. Okay. First thing is, why do we need to know the types of breast cancer? Why isn't it just enough that there's a lump in the breast, there's a lump under the armpit? Why can't we treat everything the same way? But like I said, the staining and the pattern which it belongs to, like, is it hormone positive? Is it HER2 positive? Is it all three negative, triple negative? Is what finally decides what are we going to do, how are we going to sequence the treatment. So in hormone positive breast cancers, they are slow growing varieties, where in early tumors, which means they are just localized to the breast, we may just get away with doing surgery alone. We could even avoid chemotherapy in such patients. But triple negative breast cancer, which means none of those receptors take up stain, even a small tumor more than 2 centimeter, after surgery, we would like to go with chemotherapy. So our entire treatment sequencing, or which treatment is to be given or not, is completely these days dependent on the type of the hormone receptor status, or what we say biology of the tumor. And if the tumor is slightly bigger and the armpit, the lymph nodes already involved, and it comes as HER2 positive or triple negative, in this case, we would like to use chemotherapy first, shrink the disease to avoid chances of distant spread, then go to surgery, and then do the final radiation. So whether you are going to give chemotherapy first, we are going to do surgery first, whether we can completely avoid chemotherapy, all depends on this staining pattern, which we would like to know before proceeding with treatment. Hence, a stage 1 cancer of breast may be treated differently based on what the receptor status is. A stage 1 hormone positive breast cancer may not require any chemotherapy at all, but only hormonal tablets or treatment. But stage 1 triple negative or HER2 positive will still require chemotherapy. This is why it is important for us to know the types of breast cancer apart from just the staging.
Thank you so much, sir, for explaining it to us. Okay, so let us move on to the diagnosis aspect. Can you please share us what are the different diagnostic methods that are available for diagnosing breast cancer? As it is widely said that early detection is very important. So what are the different techniques that are available? Does everybody need to go through a CT scan or PET, etc., to get diagnosis done? What would be the protocols?
Yeah, so for now, for screening which we say is done in women who show no symptoms, where there is no lump detected yet. So there we do something called a mammogram. Okay. Mammogram is nothing but an X-ray taken in two views, which is taken very close to the breast. And we can also have another ultrasound which will complement the mammogram. So we call it sonomammogram, which is advised in all women above 45 years to take it annually. Okay. This is done because so that the mammogram picks up some areas of calcification. Calcification means calcium deposits, which are only present usually in the abnormal cells. And this is the earliest sign which can be picked up very reliably by mammogram. In fact, it is even better than CT. So this we say for screening. Okay. So where this is the earliest stage of cancer, where we say just starting to come, it's still not invaded and spread, which we call it as stage 0 or cancer in situ, which means it's still within the earliest stage. So for this we require mammogram. But if a lady already comes with a big breast lump, then what we would like to do is we would first do, of course, we would do a mammogram first, and then we would go for a biopsy. Okay. Biopsy is a simple needle test where we take a sample of the breast tissue and we establish the diagnosis, and we of course process it for further testing, which I said the hormone markers ERPR and HER2/neu. And of course, if the mammogram also shows there is some axillary nodes, which means the breast cancer has already spread to under the armpits, we may require more staging because it's already spread from the breast to the armpits. We need to rule out whether it has spread to distant organs. So there we may need a CT scan of the chest and abdomen, or these days, because with the convenience of PET scan, we can image the whole body in one shot. And here we may also need a PET scan modality. So for screening, we usually mainly use the sonomammogram. But if a patient already comes with a breast mass, which is highly suspicious of breast cancer, we usually do the biopsy and then get a CT scan or a PET CT scan.
So all these diagnostic methods that you have explained as mammograms or CT scans or PET scans and biopsies, are these really affordable and accessible for general masses? Or do these treatment cost much, as people presume that cancer therapies, cancer detection is very pricey? So what are the real scenarios like? What have you experienced, with your patients so far?
Yeah, I think these days with the number of institutes or the number of centers offering CT scan, PET scan, because they have sprung up in so many places, the real cost has definitely come down. Okay? And these days they have the low dose CT scan, and so it is definitely, even in the last 5 years, it's almost the costs have come down by more than 50%. So they're definitely affordable, and more than affordable, it's easily available for patients. Previously, PET scan would probably be available only in 2 or 3 centers in the whole city. These days, every region has a PET scan easily available, and the cost is very much affordable, so that no patient is deprived of any staging or treatment. It's definitely affordable. And main thing is all these tests, except biopsy, where it involves a small piece of tissue being taken under anesthesia with a little pain. All the others are non-invasive tests, which means that it is painless, and definitely it is easily can be availed by the patient.
Thank you so much, sir, for explaining that. Along with the existing methods for diagnosis that we shared, are there any, AI-based or newer technologies that are also coming up that you would like to share with the audience so that we are more aware on these things? And what role do you feel does AI play in early detection and breast cancer? Would this be more, readily used up in future? Do you see it working that way?
Yeah, I think AI based, how it would help us is definitely there is a lot of research going on that it has not come into established pathways of screening. I have seen many companies coming up with thermal cameras. Usually, what happens with mammogram is the breast tissue is slightly compressed from two angles and the X ray is taken. So, there is a slight discomfort to the patient. So, there are many companies coming up with a non contact based testing like thermal camera, which can just pick up heat signals in the breast from a distance and try. But these are all still in the data is getting established to whether they are as good as mammogram. So this is being done, and of course, all our available data of all the existing mammograms and CTs are all being fed through neural networks through digital pathology, and they are trying to find out patterns where the computer can only detect whether this is cancer or not at a much higher efficiency or higher accuracy than humans. And it's not just about it being better than humans. I guess it's because it will reduce the work burden of considering the amount of population who needs to be screened. I think it will definitely, so possibly in the future, definitely AI may have a role with under a human supervision also to see the tests and uh, secondary evaluate the test definitely. But as of now, we still don't have an established AI based thing. Yeah.
Thank you so much, sir. And I hope in future we come up with, more established tools that integrate artificial intelligence and machine learning. Not only it would never be able to replace the human knowledge and touch, but would
Right.
help us significantly in saving our time and effort both ways in multitude of ways. Uh,
Definitely.
so there is also this thing that concerns people a lot, that is having genetic history of breast cancer. So can you please touch upon it? What does having a genetic history of breast cancer means, and how is one more susceptible genetically to develop breast cancer or any gynecological cancer for that matter, and how do these work out?
Yeah. So, see, genetically predisposed means the individual is born with a defective set of genes. Okay. So, usually we see breast cancer in the most of them, 70% or three-fourth of them, we see it in the elderly or 55 or 60 plus. But when you are born already with a defective gene, it just takes a few more additional mutations for you to develop cancer. So, if some lady develops in a very young age for lady, we would say less than 50 years. If you have, if you are detected with breast cancer, we would say please go and get yourself testing for genetic testing. Or if you have a strong family history, like immediate relative, like a sibling or mother, father has having a history of breast or any of the gynecology malignancy like ovary or endometrium, then it definitely indication to get genetic testing. Or if you have two or more relatives in the family, it can be even second degree relative like cousin or uncles. They have, then also you have to get genetic testing. So what we say is around 10 to 15% of breast cancer could possibly be attributed to a genetic defect. So we say anybody young, less than 50 years, or who have a strong family history, or even we say some many patient who had more than two different type of cancer, like initially had ovarian cancer, now develop breast cancer. We always tell them to go for genetic testing. This is also widely available now, especially in the tier one cities. We do see it's widely easily available. They don't just test one or two genes, they come as a big multitude of panels of 54 genes, where not just the BRCA1 and 2, which are the most famous genes known to cause hereditary breast cancer. We do get a lot more information. And I think around, yeah, 1 out of 10 or per lady may have a hereditary breast cancer. So these are the things to be kept in mind. If it is very young or a strong family history or two different cancers in the same individual, we definitely need testing.
Thank you so much, sir, for bringing those, points in light. So, as we are talking about accurate diagnosis and different staging and types, and understanding these around breast cancer for more accurate, more early diagnosis, while we are talking about having family history or genetic history around breast cancer, what would be your suggestions to those who do recognize having this gene of breast cancer or cervical cancer or gynecological cancer in their family? So what should they be concerned about, and when should they go and get checked? What ages are there any specifications around these for such people? And also then later on we will talk about people who do not have any genetic history. What should be the diagnosis or preventive diagnosis protocol for them?
Yeah, for people of ladies who already are known to have a genetic susceptibility, so they should be started, like general population is 45, so in them we usually say start at 20 to 25 only, or start at 10 years prior to the age of what their siblings or their parents were detected. Suppose the lady's mother had breast cancer at 32, then the daughter will have to be started screening from 22 only, 10 years lesser. So definitely in them, younger women, we say because of the dense breast tissue, uh, mammogram may not be ideal. So in them, we recommend a breast MRI for such patients. Okay, so we usually do MRI once in a year and mammogram 6 months once. So we alternate MRI and mammogram so that every 6 months there's an evaluation of screening is being done. And once we know if there is a BRCA, which is breast cancer antigen gene, which is known to cause breast and ovarian cancer. So once the lady completes her family and she does not want further children, so we definitely do advise her. We could give her an option of getting the ovaries removed. That's one way of preventing ovarian cancer in the future. And there's also the option of prophylactically getting the breast tissue removed. I think this was made very famous, I think, by uh, Mrs. Angelina Jolie, who made big waves when in US she got both her ovaries and breasts removed, because she belongs to a Jewish community where 1 in 40 women have this defective gene, whereas in the general public only 1 in 400 have this. So these are the options which can be given. For some reason, uh, if they don't desire for the breast tissue to be removed or the ovaries to be removed, we could give them some hormonal tablets for suppression of the tumor cells which may emerge, and they have to be on regular surveillance every 6 months. And for the gynecological cancer, with either blood test and scans and mammogram and MRIs for the breast tissue. This is a must. General population, if there is no family history of cancer, then we usually start at 45. There's no risk factors, like significant risk factors like known hereditary cancer gene. Then we start at 45. We advise for annual mammogram. And of course, we advise them for a healthy lifestyle, balanced diet, less of saturated fat daily, 150 minutes of aerobic exercise a week, and the regular healthy lifestyle.
Thank you so much, sir, for explicitly explaining us all these. Another very less talked about point around breast cancer is breast cancer in males. So most of the population is not even aware that this thing can occur in males as well. So can you please shed light on how common it is in males, and if somebody, having a family history of breast cancer, suppose their mothers or their grandmothers having breast cancer, how does the risk increase in males in that family to have this breast cancer gene?
Yeah. So male breast cancer is very less spoken about. Like definitely, even males do have breast tissues, just that it's not expressed or developed. So people assume that males may not get breast cancer, but in females, like the incidence may be like 1 in 16 or 1 in 20, but in males the incidence is far less common, maybe 1 in 1,000, or maybe get male breast cancer. And most of the male breast cancers are only hormone positive, like I said, ERPR positive. And whatever we have research and studies, we have seen that male breast cancer is most common in families who harbor the BRCA2 gene. It's not the one BRCA2 gene. They are not just at risk of breast cancer, they're also at risk of prostate and pancreatic other cancers also. So I would say if there is a male where he has a strong family history of breast or ovarian cancer in his own family, first degree or second degree, like immediate siblings, parents, or aunts and uncles, or if there's also an incidence of prostate cancer and pancreatic cancer in many of the family members, then he must check this BRCA2 gene. And if he's positive, then he is also at a risk of breast cancer and needs to be screened. However, it's a very rare occurrence, but in this scenario, it should be kept in mind.
Thank you so much, sir. So, as you rightly explained, that there is, men also, if there is a running trend in their family of this BRCA2 gene, they need to be checked for these sort of, cancers as well. So, I believe counseling and awareness from the doctor's side to the patient really plays a big role in this. So if we come across, if clinicians come across a patient, person, a woman with, breast cancer gene, and she is in her late stages and has a son, a daughter, etc. So I believe this is a protocol being followed by the clinicians, that the close family members are also checked for those sort of signs and symptoms, just for preventive measures. So what would you like to say around this, around making our audience more aware that if your family person has this, so, and if you are in close relation to them, do get yourselves also screened. I am sure their clinicians are also expressing that, but so much more time is required during one-on-one sessions from oncologists, from their practitioners, or whoever that they are seeking. So what would be your advice to the budding oncologists that are watching this show, also the general public that is watching this show, around this aspect?
Yes, ma'am. I think it is everybody should be knowledge or should be aware about breast cancer and screen, because it is one of the really preventable cancers. And if not preventable, at least we can catch it at the earliest and we can cure it, because like I said, early breast cancer has almost 90% cure rates. So I believe everybody should be educated and they should know about the relevance of doing a self breast examination every month, so that they pick up the lump earliest. Visit a doctor every 6 months for a clinical breast examination. A mammogram at 45 years of age is a must, that should be explained, because these are all things which are covered under insurance in the Western countries. So it is done as a default or autopilot mode over there. But here, because all this is not insisted in insurance coverage and under any scheme, so here many of them present late. So I think everybody should definitely know, every woman, that the breast cancer screening does start in the 40s itself, and a simple thing as an annual mammogram can help you detect it at the earliest and prevent it and cure it at the earliest. The second thing is, of course, if there is the prevalence of cancers in the family, where the sibling has it, the parents has it, or the 2 or 3 more members in the family who are having it, then there should be a strong suspicion of a hereditary cancer, because only when it is detected, the next generations can be screened and we could possibly catch it early, or start the screening program from way before and try to catch it early and prevent in them. So it is very important that if there is an individual and he or she knows that there is a lot of cancers in the family, please do go ask by yourself for a genetic testing or a genetic counseling and screening to see if there is some hereditary germline mutation going on in the family. And many of them also tell me that I have seen that she says, I don't have daughters, I have only a son. So it's anyway breast cancer. So what happens in this? We have seen couple of situations where the son gets the mutation from the mother, but the son never shows any signs or symptoms, because of course the chances of breast cancer in him is much more lower. But when he goes to have a daughter in the future, which means the patient's actually grandchild, it may have silently passed on to her, and then that child may get the mutation. So it's very important whether the offspring is male or female, whether you have brother, sister, everybody get tested. So we know at what level it is passing on, and we can do the genetic counseling, and we can give a proper surveillance and a screening program for them. So it is, I think it is, everybody should be aware that this is one of the cancers which can be caught at earliest and cured when started with efficient screening at the right time. So this is, I think this is a must that everybody must know, definitely.
Thank you so much, sir. That was such an insightful discussion on various different aspects around staging, types of breast cancer, also for helping more accurate, more early diagnosis for our audience. Thank you so much. With that, we come down to the end of our very interesting session today. Let's remember that knowledge is power, and accurate diagnosis and early diagnosis is a cornerstone for effective breast cancer management. Early detection also saves lives. So please make sure to see a doctor, a specialist, an oncologist, a gynecologist, or whoever, a health specialist that you are very comfortable with, so that any signs of, early signs of breast cancer do not go unnoticed. With that, we wrap up this very interesting episode. I would like to thank Dr. Vinu Sarathy P for taking out time from their busy schedule for imparting us with wealth of knowledge and information today. Sir, thank you so much.
Thank you, ma'am. Thank you so much for having me. Thank you.
We would also like to thank our partner in the initiative, Roche, for this brilliant initiative of Breast Cancer Awareness Series for the Breast Cancer Month. Thank you so much. And we would also like to thank our audience for staying with us till the very end. I hope this session was as insightful and informative for you as it was for us. Thank you so much. With that, we sign off now. Stay happy, stay healthy. Thank you.